Good morning, everyone. Welcome to our webinar. I'm just going to give it a few more seconds just to let people join, and then we'll start. Well, good morning, everyone, and welcome to the latest in our series of CHC continuing healthcare related webinars. Today we'll be exploring the use of analytics and how we can use data to enhance CHC performance. My name is Seb Stewart. I work for CHS Healthcare as our growth director. We're an organisation that works closely with a range of CCGs, trusts and local authorities up and down the country, providing CHC support to our colleagues in the NHS. I'm delighted today to be joined by two experts in the field of data analytics, Raj Bhatt and Paul Kay. Raj, would you like to introduce yourself?
Thanks, Seb. Thanks for the invitation this morning. So, hi everybody, I'm Raj Bhatt. I'm the Head of Analytics for NHS Continuing Healthcare here at NHS England and NHS Improvement. Hi.
Thanks, Raj. And Paul, would you like to introduce yourself?
Yes, thank you, Seb, and good morning, everybody. My name's Paul Kay. I'm from Quick Solutions. We are a software provider who specialise in quality assurance and more recently in data and analytical solutions.
Yeah, thank you, Paul, and thank you, Raj. So this morning we'll be discussing how the better use of data analytics can improve performance and lead to better continuing healthcare services. And our discussion will be split into four main areas. Firstly, why key performance indicator data is collected and how it's used to provide a more rounded picture of performance and compliance. Secondly, looking at the importance of data and analytics as a driver for national policy. Thirdly, how data and analytics can be used as a tool to support governance and compliance in CHC. And then as we move into the new ICS structures, what are the challenges? What are the changes there might be to CHC data analysis standards, and what opportunities there might be, including access to tools, resources and working groups. Before I begin, can I also let you all know that there is the opportunity for you to input questions using the Q&A function on the toolbar at the top of your screen. So let's quickly move on then. So firstly, we're going to look at why KPI data is collected and how it can be used to provide more rounded picture of performance and compliance. So Raj, can I ask you, or are you able to give some insight into the motivation for the move from using aggregate data sets to patient level data sets for CHC national reporting, as well as sharing some of the benefits you see of moving to this standard of data collection?
Oh, thanks, Seb. I'd have to say, so the move from aggregate to a patient level data set is an important step for NHS continuing healthcare. For colleagues who are familiar with the aggregate data return, will hopefully be aware of that. We're requesting a key performance indicator data set and a collection which is aggregate, and I'd underline the word KPI and aggregate there on the rationale that in comparison to what we're now requesting is now a much more focused and patient-centric data set. So some of the things within the quarterly aggregate collection enable us to review key performance and compliance, which is outlined as a national standard in the NHS CHC framework. But the disadvantage of the aggregate collection is there is a narrow scope within that data collection. So some of the things we can't answer Are care packages taking place on schedule? How long are people waiting for packages of care, or how long people are eligible for continuing healthcare? So those are some of the key performance indicators we would envisage working towards and taking up from the patient level data set. The benefits, hopefully in the clues and the title, with it being a patient level data set, so we can enable a level of patient level and centric formed decisions to ascertain whether the outcomes and experiences for patients are in alignment with what we set out as standards, and again underpinned through the national framework. I think the additional benefit is we're aware that data is collected on the ground at a patient level for obvious reasons, so it's logical to assume that we would collect and process and subsequently report where it's possible to do so from a patient level data set. So the reduction in burden is much more easy to manage in the medium to the long term. And I think the additional benefit is when we try to ascertain outcomes and experiences, we're much more focused of looking at the richer and granular level of data, again at patient level, and working out for this record and this patient, was it a good experience, was it a good outcome against the national framework and standards. So that would be my kind of quick synopsis, Seb, if that helps.
Thanks, Raj. And Paul, can you give some examples of projects where you are collecting data and what you're using it for?
Yes, sure, Seb. We obviously have well, I say obviously, for those of you who know us, we have the chat tool, which collects assurance data from CCGs and presents it to the regional and national CHC teams. We have AIMS, which is more data-based and collects quarterly data on things like long waits and the timeliness of assessments, which then leads into improvement plans for CCGs based on that data. Some other examples, more recently we're working with CCGs, both upstream and downstream, providing information upwards to regulators and to people like NHS, but also for in-house purposes, and maybe collecting information from providers. So information from nursing homes that they work with, KPIs, so that they can get a real picture of what's actually going on, rather than sort of a gut instinct feel that they might have just from the conversations they're having, rather than what the data is actually telling them. Now, Jen, I've got a slide if I may share now. A couple of other projects which might be of interest to people is, and I think really borne out by the pandemic, we were involved in collecting data from the COVID laboratories, and we were presented with an issue in the spring of last year where information was being emailed into the centre. The spreadsheet versions that were being used were in many cases not capable of holding the amount of data that was being put into them. So we were able to create a solution to collect that information and present it, and obviously very vital information. And I think the importance of that has now been sort of recognised, and throughout the pandemic, data has actually contributed to saving lives. The information that they had about the number of vaccines, the number of people testing positive, the people who are in vulnerable positions, has helped, I think, really ratchet up the whole view of the importance of data, particularly in government and NHS right now. So that's certainly one project that we're involved in. And sort of at the other end of the scale, we're using data now to drive things like really innovative programs, and one of those is something called WASP we're working on at the moment, which actually measures person-centered care. So there's all sorts of aspects of data collection that is now sort of getting much more prominence as the focus increases and the value of it is certainly being recognised. So I'll stop sharing now, Jen.
Thanks, Paul. That's incredibly interesting, isn't it? That to be able to say that data saves lives. So it's not just about improving performance and services, but it having a tangible impact on patient lives is incredible. Thank you for that. So moving on then, so looking at developing policy nationally, what is the importance of data and analytics as a driver for national policy development? Raj, can I ask you a question? How is data used to compare and contrast different areas across the country, different CCGs, different ICSs, and how does that flow through into policy and guidance that's produced?
Yeah, sure. Thanks, Seb. So in terms of the comparison across CCGs and its link to policy, it's important that colleagues understand that the way we currently capture data is on a geographical basis. So we currently capture, process and report data currently at a CCG level. And one of the ways we use to compare CCGs and geographies is to compare them amongst other peers. And one of the ways we try to do that is to provide the data against an analytical technique called clustering. So that's a technique where we use to identify any unwanted variation, and I'd underline the word identify. It doesn't mean there is, it means there's scope for an investigation to determine whether there is a comparison and any unwanted variation. So from a central and national perspective, we find that's an incredibly useful technique to use to enable regions and CCGs themselves to check against the levels of standards and compliance. What I envisage occurring moving forward is, whilst we move into a new integrated care board statutory commissioner environment from the 1st of July, what we haven't decided upon yet, is my understanding, is the level of assurance that we then compare the geographies at. So whether that will be at the existing CCG geography, and for those of you who are unfamiliar, there's a new term from an analytical and data perspective called sub-ICB location, which is the CCG level geographical geographies where we've got now. So it's 106 geographies to 106 geographies, whereas the 42 ICBs are the layer on top. And the reason why I'm mentioning that is because it's important to help identify if there is any unwanted variation, enable ICBs or CCGs to compare themselves against one another. And the link to the clustering element is really important because it enables you to compare a geography which has similar geographical footprints or demographics and population data amongst others. And the link to the policy will be really important to make sure, as the policy links itself to the data, colleagues are making data decisions that links to policy, and which I'm pleased to say I think we are. So hopefully that helps, Seb.
That's really useful. And secondly, Raj, what metrics for CHC are NHS England going to be monitoring from the new CHC PLDS, and how do you think this might improve national CHC performance?
Yeah, sure. So my view on this is, I think before we even start a journey on, because we're moving to a new data source, naturally implies there's a set of new key performance indicators or new published information, and that's all very valid. I think the first and the key priority is to make sure and answer the question is that as we transition from one data source to another, or run them in parallel, which is what we're doing at the moment, are we confident that the new data source gives us the correct and right level of intelligence to make decisions? So at the moment, we're focusing our key priority on reconciliation. So moving towards a journey where, once we're confident that the levels of data in the actual patient level data set is good enough, that's when the point will turn where we'll start utilizing that data. And I think from a metrics perspective, we haven't got a definitive list of these are the new 100 key performance indicators that we're planning to produce from the patient level data set. However, we have started to think about topical areas that we'd want to focus on. And some of those topics that we've thought upon are health inequalities is a big topic. And in order to assess if there's a health inequality, we really needed the patient level data at that granular and richer data to help assess, based upon protected characteristics, is there a health inequality in a specific geographical area? Is it a specific linked to a ethnicity type or sexual orientation, or a variety of protected characteristics? Some of the other topical areas we're thinking about are waiting times and costs. So all of these are collected, of which will then process and turn into KPIs, whereas at the moment we're asking colleagues as data submitters for KPI information. So they are very different areas. As I said, the first aspect is reconciliation and then moving towards key performance indicators.
Thank you, Raj. And a question for Paul. How is data being used to drive CQC regulation and inspection methodology? And is this going to be changing as we move into ICS structures?
Well, Jen, if I can just share a slide here, I'll try and share some experiences of what CQC are talking about right now. They're looking at a single framework for inspection going forwards across all service types. Whether that quite works, I'm not totally convinced about, because how can you compare a dentist with a hospital? They're working to the same assessment framework. But I guess there will be specific indicators for each different type of provision. But I think the key thing is they're moving away from providers historically have had to compare themselves with the key lines of inquiry, and the inspection has been the primary method to determine risk with long narrative reports. And they're moving towards a way of measuring that sort of level of compliance and assurance based on something called I statements, which are what people who are receiving services, service users, would expect. The we statements are how people expect to deliver that. And then there's a big chunk which is based on evidence, and things which keep coming up are things like people's experience, feedback, and regular data collections and feedback guiding the risk that CQC think that a particular provider may or may not provide. So a different sort of format likely to come out earlier in next year, I think, is the likely view that becomes live. As far as the oversight of ICS is, then I think the CQC are going to be looking to try and distinguish themselves from NHS England in terms of their oversight. And from what I've seen, and I've gone on to various webinars and things and heard from CQC, they're going to be focusing on the leadership integration in particular. So looking at pathways and the way they're working within an integrated care system and focusing on quality and safety. So I think that is what they're saying will be their areas of focus, and they'll be looking to, from the information they gather, obviously focus on some of these things like improving outcomes for people. So I think it's still not tightly defined as to what that is going to look like, and how that sort of crosses over. But I think certainly the intention is for CQC and NHS to work really closely together and not try and tread on each other's toes and complement each other as part of that ongoing oversight process.
Thanks, Paul. Just someone's asked if slides can be shared. I don't know if are you happy for the slides that you put up to be shared? Yeah, brilliant.
Yeah, sure.
Okay, so Jennifer, can we organise that after the event? Brilliant, excellent. And a couple of questions. Thank you everyone who responded to the survey that we sent out. I think one of the sort of key areas that came out is that 65% of respondents see CHC governance as an area that they would like to improve. I don't know whether, Paul, you're able to provide, do you think that what you've just described from a CQC perspective will help improve governance, make it easier for people to provide that level of assurance in CHC moving forward?
Well, I think it's all part of a wider picture, isn't it? Where the focus on governance is increasing all the time. In fact, I picked a random sample of 50 CQC reports from trusts, and the number one area for sort of concern for the CQC was actually information governance and quality assurance. So it's very much at the top of their agenda. Now, how CHC teams are able to work on that, I would maybe refer them back to the chat tool, which is going to be revised with more appropriate, I think, key lines of inquiry going forwards. But that will contain significant guidance on what good governance looks like, the role of the board in their oversight of CHC, people understanding that CHC is a key element of service delivery within the CCG currently, and then moving forwards to the ICS. So I think there will be a lot of information and guidance in chat and in other resources, and leadership, I'm sure, from NHS regional teams about the measures they would expect to see in place.
Thank you, Paul. And Raj, a question for you. You mentioned that a topical area was health inequalities. We've had a question coming through that someone saying they're concerned that health inequalities, waiting times, etc., already been gathered by other areas such as PCNs, etc., and they're concerned that do not end up completing work already being actioned. How do we sort of make sure that we're not duplicating work that's already been carried out?
Sure, thanks, Seb. So I think my view on this is, whilst there's lots of different services and areas within the NHS collecting specific information around health inequalities, I certainly haven't seen anything specific that's CHC. In order to make it specific to CHC, it needs to both tie in, the definition of what we mean when we say a health inequality can be very easily reflected perhaps in a primary care network. I'm assuming on the rationale that they've got lots of primary care level data linked into their practices, but is that then joined on to a patient level focused data set for CHC? And I think until it's not, we shouldn't automatically assume because it's being captured over here and then the decision being made over here. What we're missing is actually at the heart of the engine room is actually what's happening for CHC patients, and you can't join the two together until you start capturing data at the correct level. But I think it's a fair comment to assume that obviously as data is being captured in primary care networks, obviously there's a central health inequalities team and that link to the PCN, what the outcomes are of that, which I'm probably not best to comment on, but I'm happy to answer anything specific from the CHC perspective.
Thank you, Raj. So just having a look, there's a couple of other questions that have come through. We'll talk about consent a little bit later. Does data capture referral source or provider, as this can have significant impact on CHC delivery, i.e. key information not provided? This could impact on outcome, but would not be the fault of the CHC team if it was refusal on the part of the provider or misleading poor information provided at the point of referral. When looking at outcomes, all these sort of factors need to be considered as CHC service. It's not isolated and dependent on cooperation with other parties. So Raj, I don't know if you're best to answer this, but how do we ensure that, when we're looking at data relating to CHC, it does take into account the impact that other parts of the system can have on performance and things like that?
Yeah, sure. Thanks, Seb. So I think if I just pick up on the referral source element of the question in the chat. So from a data set perspective, we're clearly asking for referral sources and a variety of other patient-specific information. This is exactly why we've ended up with a data set that has a level of granularity and a level of mandation. So when you're thinking about it from a CCG perspective, the data that's been captured on your system, and then your interplay and link to the actual provider delivering the care, and how that process works from the provider to collection to submission on the system to then subsequent reporting. The whole information standards notice is absolutely key to this, which is a reflection of it being a statutory return. So as it's a legal and statutory return is the first thing to mention. So throughout this whole journey, we're working with the expectation is, whilst it's a statutory submission from CCGs, we equally understand as the providers delivering the care need to have a focus and view on this subject, things like source referral, as some of the comments have said. But when it comes to submitting the data, we have different levels of mandation. So mandatory is a reflection of when you're submitting data as a CCG, it's mandatory to submit this data set item. And if it's not available, it will reject the record. Whereas if I pick on the source of referral, it's a required data set item. And I think picking on the comment where, there could be scenarios where you may not have that. And that's exactly why we've enabled the data set to be flexible and fluid, saying obviously it should be captured, but in scenarios where the example, I think someone who gave the comment, well, if it's not given from the provider's perspective, you will struggle. But I think my recommendation is to keep that dialogue open with those providers. If you're struggling and interplay the information standards notice would be my recommendation.
Brilliant. Thank you very much for that. Just trying to see where we are. So moving on then, so using data analytics as a tool to support compliance in CHC. Raj, can I ask you for your reflections on this, and how will the updated consent form change the consent practice process? And Alison from Newcastle has asked a couple of questions on consent as well. She's asked, if an individual withdraws consent, how is this recorded, and will their data be removed from the file prepared for the PLDS? And secondly, if patients do not consent, if there are a large number of patients that do not consent to sharing, does this skew the number recorded against the total number of patients that are giving consent?
Yeah, sure. Thanks, Seb. So I think it's important to reflect that the consent form, which was recently updated for continuing healthcare, which is available on the CHC delivery model, there isn't an anticipation that we're changing clinical practice on this topic, is the first thing to mention. The second thing to mention is when we're collecting data, processing data and reporting data, there isn't an expectation that we're seeking consent of patients. And I think this is quite important. So within the consent form and under GDPR, there isn't a requirement to ask patients for their level of consent in order for processing personal data. So within the consent form, there's a number of hyperlinks, which when you click on will give you visibility of the levels of statutory and legal obligations that we have as NHS England and I around what patients can consent or not consent to when it comes to the patient level data set. So I think there's been a bit of confusion around colleagues' understanding of what happens if as we're implementing a new data set, all patients have to engage in the process of consenting or not consenting. The answer is no. What we're expecting is that as colleagues are completing out the consent form, colleagues are reminded of their data will be processed as part of the patient level data set. And if they've got any questions or concerns around there's a clear hyperlink which gives colleagues visibility of why we're collecting data and for what purpose. So hopefully that helps. I know there was quite a large webinar recently generally around consent, but we've hopefully tried to make that as clear as possible directly on the form, and it has gone through all the relevant governance arrangements in NHS England, including information governance, and signed off by our data protection officer to make sure what we've updated on the consent form is an accurate reflection and meets the legal obligations also.
Great, thanks, Raj. And Paul, we know that people, you know, organisations use spreadsheets to capture data. Are there better ways that simplify that make it easier to capture required data, useful data?
Yeah, thanks, Seb. Obviously, there are a variety of ways of actually capturing it, and then there's the use generally of spreadsheets to try and sort of crunch that data once you've got it and make it into something meaningful. So I would advocate turnkey solutions where you can carry out online data collection through forms and things like that. But we have examples where people are collecting information over telephone surveys, which have been very successful, or even paper. So you have to still bear in mind that a lot of the, certainly patients, or when you're looking for patient satisfaction surveys, may be of a certain age where filling in a form on a smartphone or on a web form isn't their number one way of doing it, or even assisting them. So providing a way so somebody can record an answer electronically as they're asked. So there's lots of ways of collecting the data. The problem inherently with spreadsheets is, I think, a lack of in-house expertise quite often. We all think we're the world's greatest experts in Excel or something, but actually turning that into meaningful information is a challenge for people. Whereas systems these days, analytical systems, will take that information and present it in real time and provide filters and lots of graphs and charts and outputs. Because I think one of the key challenges is, once you've collected the data, is communicating that in a way that people can easily understand, and being able to present trend analysis, so you're comparing things nice and clearly with clear graphics, is a real skill and a real way of getting the benefit from that data. If you just collect it and then can't communicate what the results mean in a simple, straightforward manner, then you're not achieving everything that you should. So yeah, I think use the right systems to try and collect that information. Spreadsheets obviously still have a role to play, but I think there are better and more capable analytical systems around that you can use for that.
Thank you, Paul. And Raj, Kevin's asked a question on whether you have a view on whether the interoperability of systems within an ICS will affect the quality of data and how we use that data. He's thinking particularly of ASC data.
Yeah, thanks. So I think my view on this probably links back to the ICS design framework, where essentially what's being requested from the system universally is to enable integrated care boards to have a level of digital and data maturity. So in my discussions with a number of CCGs, I think it's become apparent that some geographies are maybe further ahead, some are just on the start of it, some are in the middle. So I think it's definitely important to recognise that, because colleagues are in different places, that we need to get to a point where we're all using, standardized processes and systems. And one of the things we're trying to do to help geographies on this subject is, where we're receiving feedback directly in my team directly, which is the CHC data team mailbox. We're working very closely with NHS Digital to help support technological developments. So where we've got current fragmented systems or geographies who've got A system over here, B system over here, and C system over here, or actually it's covering one current ICB geography, we're trying to help stitch some of that data together. So my view is, where we've got digital and data maturity, we're certainly expecting colleagues to get to that point. But I think that we're on a period of transition here, particularly as we move to a place of place-based geographies, which is still yet to be defined. So I think until we get to that position, we're very likely to have a level of fragmentation. So I'm keen to kind of help colleagues on their journey as best we can jointly with NHS Digital. But if there are any specific scenarios, then I'm happy to engage, and please do get in touch, is what I'd say.
Thank you, Raj. So one of the sort of key strategic aspects that's hanging over all of us at the moment is the move to ICS structures, and so what I wanted to sort of move on to now was what we see as the challenges to collecting data. Will there be any changes to standards, and what are the potential opportunities there? And I'm thinking around access to tools, resources, and working groups there might be. So if I can ask you both to sort of reflect on that, and Paul, a specific question for you: how will sort of revised standards, chat standards, drive accountability for performance, and how will reporting feed into this?
Thanks, Seb. I've got a slide on this, Jen, so I'll just share now. So first of all, there is the restructure itself, and what we understand is from July, when the new ICSs come into being officially, the ICB sublocations, as Raj was alluding to earlier, they will be expected to complete chat. However, the oversight of that will be for the ICS rather than for the NHS regions. So the ICSs will be working more closely with their CCGs, and we hope and we expect that the standards within chat, the CLOEs that people have to put evidence against, will be revised to reflect the way that is structured. So at the moment, the chat tool talks about the move towards ICSs. It's now about, okay, what's in place, and being able to report and progress that. The ICSs themselves will also be expected to complete chat. So this will be something new, and there will be CLOEs we expect to for the ICSs to complete, to show where they're progressing, and to provide assurance to the NHS regions. I believe NHS regions themselves will be in the first year monitoring the evidence from the systems from both the CCGs, the sublocations, and the ICSs, but the move will eventually be for it to be the sublocations will be the responsibility of the ICS, and then the NHS regions will monitor the ICSs themselves. So there, I think, an increasing role for the regions in this, and obviously we'll wait and see what that means in terms of the actual standards. But I think the mechanism is likely to be very similar, with ongoing reporting through the AIMS tool and the assurance being provided through chat, but being honed to reflect the current structures rather than what's been happening up to now.
Thanks, Paul. And Raz, I just wanted to talk to you now about what you sort of foresee as some of the sort of key challenges as we move into ICSs in the collection and reporting of data, and how this might impact on CHC performance.
Yeah, sure. Thanks, Seb. So from a challenge perspective, I think it's an obvious statement to say there is going to be a journey for all colleagues to improve data quality and improve a level of reconciliation when we're comparing both the aggregate and the patient level data set. So I think the data quality is going to be at the heart of what we're trying to achieve, at least for the next few months, maybe quarters. So I think that's going to be a challenge, and that's born from the statement I mentioned earlier around that for certain geographies they might have a level of fragmentation of systems or processes, obviously moving towards that being singular. I think the other challenge that I foresee is, with there being at points of there being fragmentation, we expect that geographies will be submitting independently, so as I said, to the different systems. So we're trying to certainly help with that, but we do need geographies to come forward if there are any issues on that topic. I think the other kind of tool or technique that we can help with this is just a reminder to access the internal Tableau-based reports that we have available on our future collaborations platform to help with some of those challenges. So where we've got performance or compliance challenges, and when we produce reconciliation reports, that mechanism and that platform are actually going to be pretty fundamental. And the last item, I suspect, is probably going to be a mechanism of how we submit data. So what I mean by that are data platforms. So some of the feedback we've taken on board since the original comms that got sent out in November, for colleagues who remember from a CHG perspective, was around implementing a new data platform called MESH, which is the message exchange for social and healthcare. So we're working very closely with NHS Digital to make sure we have improvements in that current data platform, but also when we move towards a what I described as a new and improved platform, of which we haven't got a definitive name from our NHS Digital colleagues on this. And I think that's really important. And we're trying to get to a process where it's, maybe 2 or 3 clicks of a button from the point of view extracting the file, submitting the data, quality assuring it and submitting, in comparison to what we probably have something like 5 or 7 clicks of a button. So we're trying to reduce the burden at every stage of the process. So that's one of the challenges I think we'll collectively have to work through over the coming months and quarters. Sorry, Seb, does that answer your question?
Yeah, no, that's fantastic. Thanks, Raj. And I suppose a sort of supplementary question to that is, what sort of tools, resources, working groups would you recommend to people on the call, to CCGs, to ICBs who are looking to leverage data and analytics to help them improve their efficiencies, their performance? Do you have any views on that?
Yeah, sure. So from a tools perspective and data analytics, I'd certainly recommend reviewing the internal Tableau-based reports, which I mentioned earlier, to help ascertain, what's occurring within their, in their local geography, and better yet, what's happening with their peer geography. And don't feel reluctant to not share that information amongst yourselves, because it's all accessible internally, so you can see each other's information at a very aggregate perspective, and equally sharing that with local authorities as and where it's required to do so. And the additional tool is taking a much more deeper route into some of the documentation that we've published adjacent with NHS Digital, which is available on the NHS Digital CHC PLDS hub. And sorry for the long list of acronym there, which really gives some really helpful information around scenario specifics, of how best they can capture information on the ground and how best they can interpret that. But in terms of a working group, one of the things we've started to think about is having a concept of a user acceptance testing group. And hopefully the clue's in the title there, where as we progress with the journey of making amendments to the data set, and I say this at the very start of a journey where we haven't got any data yet, we're already thinking about what the next 12 months and 18 months will look like, and that's really important to make sure we start that level of planning now, if we ever want to make any improvements or suggestions to the next iteration of the patient level data set. So in terms of a working group, I'm really keen to hear from users on the ground of what those suggested changes could or should be in the patient level data set, is the first thing I'm thinking of. And the second is that, are there any improvements of how we can collect or even potentially pull any of the data? And I think that the last word I used is really important, because at the moment we're in an environment, and we have been doing this for, as long as I've been around in the NHS, we're really good at collecting data in the NHS. And what we need to move towards is using data in a much more smarter way and pulling the data where it's appropriate to do so. So that would be my view of some of the things I think we need to kind of think about collectively across all of CHC.
Great, thanks, Raj. And before I move on to Paul, I think there's sort of a number of people sort of concerned about the amount of work and effort that around sort of recording information and uploading it. And I think someone asked the question, or they said it would be great if all NHSC reports could be generated, pulled directly from systems. What's your view on that?
Yeah, so I'm very keen to head down that rabbit hole. Would be my view. As I was saying, because I'm a fan of pulling the data, so there's less burden. I think I've equally sat on both sides of the fence, so people know my background of in a provider environment, submitting data, getting asked for lots of information, and equally sat in a commissioning environment and asked for the assurance element. So with both those hats on, I'm keen to reduce that level of burden. And there's two things I'm thinking of. One is around pulling the data. But when I say pull the data, I think it's important to recognise that concept really needs to be trialled and tested in a much more deeper environment and has a much more detailed discussion directly, not only with CCGs, but with system suppliers and NHS Digital, because there's a number of really important stakeholders to get that right. And that if we aim to achieve that, that will certainly reduce the burden. I think the second thing is we really understand that whilst we're asking colleagues to complete 2 data sets concurrently until we reach a level of reconciliation, we will certainly move to a level of reducing burden and decommissioning the aggregate flow. But as I said earlier, I think the key emphasis is around making sure the reconciliation, the data quality is right to begin with. So I think that the journey that we all need to get towards is improving the data quality and then starting to working out, right, how can we pull the information to reduce the burden. The one key aspect that I would urge colleagues to think about is that as we pull the data, what's that clearly needs to be worked through, the level of quality assurance and the governance behind that is absolutely fundamental, because pulling the data technically would be, you know, once we've gone through those hurdles and gone through a user acceptance testing group, is how do we then assure ourselves that the data that we are pulling is accurate and has been signed off individually by 42 ICBs or 106 geographies for better description. So technically, it's certainly something on my radar to answer your question. And the last comment I'd mention around burden is before any data collection is stood up, there is a national burden assessment that's undertaken across any national data collection. So within the data provisions notice, there's a whole chapter dedicated around data reduction and burden and the estimate cost and the number of man hours that we're expecting to have, or hours, sorry. And that's all available in the public in the data provisions notice. So if you haven't seen that, I'd certainly recommend a read of that.
That's great, thanks, Raj. And I think you know that sort of point about the sort of quality of data is absolutely critical, and for ICSs to be effective moving forward, you know, that there needs to be that sort of focus on quality data. Paul, can I ask you a question around how ICSs can ensure their populations are well represented in their data and health needs?
Yes, certainly, Seb. So I guess the sorts of information that the local population will be most concerned about is, you know, their experiences of care and how they can their voices can be heard, and that translated into more effective and efficient services. So talking about collecting data about, you know, the pathways and effectiveness of those pathways. Lots of patient surveys saying I went through this smoothly or not, and I was able to respond back to the eventual commissioners of that care with my views and have those heard. So sort of almost harking back to what I was talking about with the CQC, where people's experience, that feedback, the population having an opportunity to say what they think, collecting that in an accessible way at lots of points in the process. So that feedback is really important. I mean, there's data at different levels. There's data from the systems that tells you what was happening, but then there's that feedback from the public, from staff, from people involved in that process, which all gives you that sort of overall picture. And then once you've got the data, how you present it is really important, because if you are able to show that in ways that people understand and present that to the public, so they don't feel like the wool's being pulled over their eyes, they haven't gone to the trouble of giving their feedback and then they never hear anything again. You know, they want to see that presented, and social media, websites, there are lots of ways of communicating the results of that data, which I think ICSs need to show if they want to engage with their own populations about, you know, the effective use of data and how it's actually being used to change the quality of services.
Thanks, Paul. And there's a very interesting comment in the Q&A where someone has said, you know, clearly it's about the benefits of the data and how that's used to continually improve and inform services, and getting this right. And you know, the view there, which I think is absolutely sort of spot on, is that you know, data needs to be recorded correctly and used appropriately, so that you know, it can be used to support improvements locally, and I guess nationally as well. So yeah, that's a really important point. So look, we're coming to the end of our session now. I just wanted to sort of ask both of you, if I can, for any sort of final reflections before we close. Raj, was there anything else that you wanted to sort of add to the discussion that we haven't covered, or that you think is particularly pertinent?
I probably focus on just having a big thank you from myself to all CCGs and suppliers, particularly as we're going through a period of change with, you know, integrated care boards, a new data set, trying to improve reconciliation and data quality. I appreciate it's not an easy journey, because I've been on both sides of the fence, as I explained earlier. So I think some of the comments that we're receiving to our mailbox have been very beneficial for to make us better understand some of the scenarios locally, to help you and wider colleagues. And we're definitely listening to colleagues on the ground to help work out how we can help reduce the burden. And I think sometimes it's not seen, because we're obviously talking independently to one CCG at a time. So we're hoping to reflect that better on our upcoming webinar. We have one later this month for NHS England. So thank you. That's what I wanted to say. That's right. Hope you found it helpful.
No, it's been great. And Paul, can I ask you a similar question? Any sort of final reflections, any sort of key points that you'd like to sort of make before we close?
Well, I think as a technology provider, we're really trying to step up to the plate here. So I think there are more and more technical solutions available to support the collection of data, and you'll be quite surprised about the possibilities out there for presenting that information and acting on it. It's not one thing collecting the data, it's what you do with it. So the ability to have automatic responses to data that trigger certain activities. AIMS is an example where if a CCG is not meeting the target, an improvement action request is automatically generated from the data. So it's about making real improvements to services using that data in the right way, and you know, embrace the technology which is available that can help you do that.
Thank you, Paul. So Raj, there's a question that's come through anonymously. Can you confirm which data provision notice covers the PLDS, as I can't see the obvious one? I don't know if you're able to answer that.
Yeah, I can pop it in the chat if I can, or I'll send it as a post-meeting note. But we've definitely published the data provisions notice. It's available in the public domain, and we've sent that out on, I think, on the 29th of March. Don't ask me why I remember that date. But yeah, we've definitely circulated this around to all CCGs and even suppliers. So it definitely exists, and I'm happy to share that.
Okay, well, look, thank you very much, everyone, for taking the time to join this call. for me it's been really useful. Clearly, there are a number of challenges moving forward, but it's also very clear that there's a lot of good work going on to try and support individual organisations as we move into ICSs. Raj has made it very clear, and I'm sure Paul as well, that look, if there are any questions that you might have, any support you might need, Raj, Paul, their organisations, us as an organisation, we provide software systems that can support as well. Please do get in touch. And I just wanted to say, yeah, thank you very much to Paul and Raj for taking the time out. I know you're both very, very busy people, but I think it's very useful for you to be able to sort of share your views, your wisdom, and your experience. So thank you both for joining our call today. Have a very good weekend, everyone. Stay COVID-free, and I hope it's a good one for you. Thank you very much, everyone.